you paid, and the love that you showed, and the prayer that you made. I will make Jesus proud. Lord, the praise that you paid, and the love that you showed, and the prayer that you made. I will make Jesus proud. Who will be many that pray? Who will be many that preach? Who will be many that proud.
The people are hungry, oh. The master is in need of blessings, so I pledge my allegiance to the one who has called me, oh. I will make Jesus proud. The nations are waiting, the people are hungry, oh. The master is in need of blessings, so I pledge my allegiance to the one who has called me, oh. I will make Jesus proud.
You paid, and the love that you showed, and the prayer that you made. I will make Jesus proud. Lord, the praise that you paid, and the love that you showed, and the prayer that you made. I will make Jesus proud. Who will be many that pray?
Proud.
paid, and the love that you showed, and the prayer that you made. I will make Jesus proud. Lord, the price that you paid, and the love that you showed, and the prayer that you made. I will make Jesus proud. We will be many that pray. We will be many that preach. We will be many that fast and deep. I will make Jesus proud.
About me to follow. I must walk the walk of the one who sent me. Oh, while it is day, we must walk. Oh, hey, we must walk, oh, till we see him face to face. The nations are waiting, the people are hungry. Oh, the master is in need of us, so I pledge my allegiance to the one who has called me. Face to face, the nations are waiting, the people are hungry. Oh, the master is in need of us, so I bless my allegiance to the one who has called me. Oh, I will make Jesus proud.
Raise your voice and shout, come on.
Non-stop, on 240. Then she gone, hold on me to road. I'm steady revving, monte throttle. Got eyes on the prize. Babala, any police snatching from his hand. If I just lower me, Rito Kakumi, that's why I follow.
Decided to follow Jesus. I have decided to follow Jesus. I have decided to follow Jesus.
I can never turn back. It's already too late. It won't make sense. Where am I going to? It's already too late. I've already come too far. It's already too late. We won the war. We will spend the billions. We will spend for Jesus. We will shift the culture. We will heal the sick. We will raise the dead. Transform the nation. Till we hear well done. We will fund the war. We will spend the billions. We will spend for Jesus. Till we shift the culture. We will heal the sick. We will raise the dead. Transform the nation. Till we hear well done.
Decided to follow Jesus. I have decided
Raise your voice and shout. Come on.
Going back, non-stop, on 240. Then she gone, oh damn it, root. Yeah, but I'm steady revving, Monte throttle. Got eyes on the prize, oh. Babala, any couple. Snatching from his hand. Even I just beat on that one.
I can never turn back. It's already too late. It won't make sense. Where am I going to? It's already too late. I've already come too far. It's already too late. We won the war. We will spend the billions. We will spend for Jesus. We will shift the culture. We will heal the sick. We will raise the dead. Transform the nation. See, we hear well done. We will fund the war. We will spend the billions. We will spend for Jesus. See, we shift the culture. We will heal the sick. We will raise the dead. Transform the nation. See, we hear well done. Raise your voice and shout. Come on.
go na road, they say I don't know road. Every me more, nine they move me, they lead me, they go. On God, mine is made up. Of course, no going back. Non-stop, on two ports. Then she gone, oh damn it, road. Yeah, I'm steady, revving, Monte throttle. Got eyes on the prize. Papa line, he can't police, snatching from his hand. If I just know I be read, oh, that's why I follow.
I can never turn back. It's already too late. It won't make sense. Where am I going to? It's already too late. I've already come too far. It's already too late. We won the war. We will spend the billions.
We'll spend the billions.
We will spend for Jesus.
We'll spend for Jesus.
We will shift the culture.
We'll shift the culture.
We will heal the sick.
We will heal the sick.
We will raise the dead.
We will raise the dead.
Transform the nation.
Transform the nation.
Till we hear well done.
Till we hear well done.
We will fund the war.
We will fund the war.
We will spend the billions.
We'll spend the billions.
We will spend for Jesus.
We'll spend for Jesus.
Till we shift the culture. We will heal the sick. We will raise the dead. Transform the nations. Till we hear well done.
I go na road, they say I don't know road. Every me more, nine they move me, they lead me, they go. On God, mine is made up. Of course, no going back. Non-stop, on two ports. Then she gone, oh damn it, road. Yeah, I'm steady, revving, Monte throttle. Got eyes on the prize. Papa line, he can't police, snatching from his hand. If I just know I be read, oh, that's why I follow.
I can never turn back. It's already too late. It won't make sense. Where am I going to? It's already too late. I've already come too far. It's already too late. We won the war. We will spend the billions.
We'll spend the billions.
We will spend for Jesus.
We'll spend for Jesus.
We will shift the culture.
We'll shift the culture.
We will heal the sick.
We will heal the sick.
We will raise the dead.
We will raise the dead.
Transform the nation.
Transform the nation.
Till we hear well done.
Till we hear well done.
We will fund the war.
We will fund the war.
We will spend the billions.
We'll spend the billions.
We will spend for Jesus.
We'll spend for Jesus.
Till we shift the culture. We will heal the sick. We will raise the dead. Transform the nations. Till we hear well done.
To follow Jesus.
Raise your voice and shout. Come on.
Me only choice. I go now road that say I don't know road. Every me mom. Now in they move me, they lead me, they go. On God, mine is made up. Of course, no going back. Non-stop, on 240. Here she gone, oh damn it, road. Yeah, I'm steady revving, monte throttle. Got eyes on the prize. Bapanda, any police snatching from his hand. If I just you know why we talk about me. That's why I follow.
Decided to follow Jesus. I have decided to follow Jesus. I have decided
I can never turn back. It's already too late. It won't make sense. Where am I going to? It's already too late. I've already come too far. It's already too late. We won the war. We will spend the billions. We will spend for Jesus. We will shift the culture. We will heal the sick. We will raise the dead. Transform the nation. See, we hear well done. We will fund the war. We will spend the billions. We will spend for Jesus. See, we shift the culture. We will heal the sick. We will raise the dead. Transform the nation. See, we hear well done.
decided to follow Jesus. I have decided to follow Jesus. I have decided to follow Jesus. Turn it
Attention, please. All right, thank you. Good morning, distinguished ladies and gentlemen. May I please plead with the people sitting at the back to occupy the front seat so that we can start the program. Those of us sitting at the back, please let's come forward and occupy the front seat. láwọn kan tí wọ́n pè àwọn ọmọ ìṣẹ̀ká tí wọ́n ṣe mí ìmọ̀ọ́mọ̀ o. All right, thank you, everybody. Good morning, distinguished ladies and gentlemen. I welcome everyone to the third postgraduate school interdisciplinary discourse lecture series with the theme of today being scientific, psychological, and legal correlates of patient safety incidents. Without any further ado, we want to go straight into the program. May I please crave our indulgence to stand as we begin this program with anthems. Shall we please stand as we take the national anthem, the Ondo State anthem, and the Unimed anthem.
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace or battle honored, and this we count as gain. To hang on to our children a banner without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed. And so with peace and plenty, Nigeria may be blessed.
Iṣẹ́ wa mẹ́wàá fún ilẹ̀-èdè wa. Kàgbéga, kàgbéga, kàgbéga fáyé rí. Ìgbàgbọ́ wa ni pé bá ti bẹ̀rù làbọ̀ mọ́. Ká ṣiṣẹ́, ká ṣiṣẹ́, ká ṣiṣẹ́, ká jọlá. Ìṣọ̀kan àtòmìnira ni ẹ jẹ́ ká máa lépa. Tẹ̀síwájú fọ̀pọ̀ ire
much. We may be seated. All right, thank you. In 2002, sometimes in September of that year, a day that was supposed to be a day of joy almost turned into something we didn't expect. It is the joy of every father or a father-to-be looking forward to see that I'm going to have a child. But something drastic happened. While I was waiting to get the news that would turn me into a father for the first time, a nurse came to tell me there was a challenge. After the birth of my firstborn, that they left a cotton wool inside my wife, and that led into a serious complication. The baby was kicking, bouncing, doing well, but will I ignore my wife at the expense of a little thing that just came that I still have no connection with? That almost turned a day of joy into sadness. But luckily for us, the medics were able to solve the problem. And the mother survived, and the child also survived. I am sure this kind of story is not peculiar to me. It is a story that cuts across almost all the fabrics of our society. We all have one story or the other at one point, whether we have experienced medical accidents in a way at a point in our life. And then I asked this morning, when I started reflecting on what we are to do today, one of the speeches delivered by my father, even before I was born, I stumbled on it somewhere. He delivered a speech in 1968. And I saw something, just one line in that particular speech, where he said, when things are not going the right way, must we then fold our hands and continue to loll lackadaisically in the armchair of unwillingness, doing nothing about it? He answered the same question himself, and he said, no. And for that, what we are doing today is not just a lecture, it is something much more than a lecture, addressing a fundamental challenge that almost every home in our society had passed through at one point, may pass through tomorrow, and still happening within our society. And the approach also to the whole thing makes it much more interesting. This is more than a lecture. And on behalf of the Vice Chancellor of the University of Medical Sciences, Professor Ebun Olua Aderonke Adejuyegbe, a Professor of Pediatrics and Child Health, and fellow Nigerian Academy of Medicine, I welcome everyone to this special lecture. Special because it is also beyond the lecture. It is also a day that we are going to celebrate one of the people who have contributed immensely to the growth of this university, almost since inception. So what we are here to do today, we learn, we unlearn, and then we relearn. And at the same time, we celebrate a man who has done immensely for the School of Postgraduate Studies of this university. And please, I want us to cooperate fully. This is a day we will never forget. Fasten your belt. Something is about to happen to you. Unconfirmed report is telling me here that the Vice Chancellor is around. Unconfirmed, I'm not sure. Okay, whenever she comes in, we are going to introduce her duly. Ladies and gentlemen, we have in our midst this morning the Deputy Vice Chancellor, Academics, also wearing the cap of the VC for today, because she's also representing the Vice Chancellor. I have the honor to introduce to us this morning Professor Rose Angela Onwuba, a professor of molecular and cellular parasitology. Please, we can do much better than that. She came in purposely because of this program. For some days, she has not been around, and that is to tell us the significance of this particular lecture. The acting registrar was initially around. I don't know if she's still around, but I recognize the acting registrar of the university, Mrs. Atunwa. Please, a round of applause for her. I was told the bursar also was invited. I recognize the bursar of the university, Mr. MSO Shitu. I also recognize, especially this morning, the coordinator of the university library, Dr. Biliamin Ukwola. And with the permission of the Deputy Vice Chancellor, I would like to use the Chairman, Committee of Deans, as a point of contact to all the deans here present, Professor Ezekiel Adebayo. Also, with your permission, Ma, I want to use Professor Augustina Duilemi as a point of contact also to all the directors in the house today. Please, a round of applause for all the directors. I want to bring some other people to this other side who are very significant to the program that we have here today. I want to bring to this side of the divide quickly the Dean of Postgraduate School. And please, this is the way we'll do it. Today is his last day in office as the Dean. I did something small this morning that let me get to know Professor Azuzu the more. And I discovered that why I was still struggling to, why I was still like in part 1 or thereabout, somewhere in a school in Ondo State here, and then Baba had become a professor. I said, wow, this is a professor of all professors. Almost all universities will have one person like that. Professor Asuzu is a professor of disciplinary public health and community medicine of the College of Medicine of the College of Medicine of the University of Ibadan since 1995. That was a long time. I think that one first deserves an applause. And he had been a consultant on population and population and clinical epidemiologist, community and occupational physician to the University College Hospital Ibadan since 1987. So I was in primary school. Yeah. Distinguished ladies and gentlemen, please kindly do something for me with a standing ovation. Let's bring this cerebral scholar, the man who has trained several people in the course of his studies, the man who has contributed immensely to the growth of this university, the man who has reshaped how postgraduate. Thank you very much, everybody. And interestingly, the person that will take over from him is also ready and is going to start the race tomorrow. He asked me specifically early this morning to have to make it to this event. As we speak, it's in Kwara State. One of the things we pray for, our professors are relevant and they are being celebrated everywhere. It's at Kwara State University in Malete. As we speak, to supervise a PhD dissertation as we speak. And he specifically asked me, please apologize to all. I would have loved to be here and to listen to Baba when he's going to talk. Baba has something for all of us this morning. I also want to quickly bring to this side of the divide our lecturer for today. He's not a stranger to us. I have been asking him how he has been able to do what he has done. How you are going to get degree in basic medical science, degree in medicine, degree in law. That law is another issue. I'm not just stopping at first degree, second, and then PhD, also in law, combining the two. So that's why occasions like this are very important. We must always come around to listen to people like this, who have become repertoire of knowledge, people that you will listen to in one day, and you will have learned something you will learn in 4 years within a single day. That is what is going to happen here today. Distinguished ladies and gentlemen, I have the honor to introduce to us this morning Professor Leroy Edozie, the Dean, Faculty of Health Law and Humanities. I also use Professor Oyeyemi as a point of contact to all professors in the house. I'm doing this for time so that we can, I recognize all the professors in the house, using Professor Oyeyemi as a point of contact to all of them. You are welcome to this event. I also recognize all the non-academic staff. I use the auditor of the university as a point of contact to all the non-academic staff. You are all welcome. But I must not fail to recognize somebody in this auditorium this morning, and that is the chairman local organizing committee. And I will tell you why. I will tell you why he needs to be recognized. He has had sleepless nights because of this event. Till this morning, early this morning, we were still chatting. He will say, please, that thing must be ready. Oh, this other one, how do we get it done? That's somebody who has put in a whole lot. And when you check his background, you will know he has no choice than to work the way he's been working. I introduced also this morning to us a specialist psychophysiotherapist in orthopedic rehabilitation and the rare field of rehabilitative pharmacotherapeutics, the Dean, Faculty of Medical Rehabilitation, Professor Teslim Onigbinde, who is the chairman local organizing committee for this particular event. Ladies and gentlemen, I must not fail to recognize all the students in the house. You are part of the people that will make this program tick today. I want to say everybody is welcome. Please let's put our hands together once again for ourselves. Distinguished ladies and gentlemen, without any further ado, the man who is passing the baton on to the next person, the man who has affected positively the field of community medicine, the man who has touched lives all his years, molding minds, teaching people, creating a better society where everybody can live, will be welcoming us to this event with his remarks. I call on the Dean, PG School, Professor Michael Azuzu.
Good morning, everybody. DVC card representing yourself and the Vice Chancellor. All the other principal officers of the university who are here. Leroy, my friend of a long time. Everybody else here. I am very happy to be able to say a word or two before I leave the office of deanship of this postgraduate school in this university. Those who are here and those who might get the booklet to look at it afterwards will know that what we are doing in this lecture is where we want all of you to be able to give this lecture. That some of the things that are written in our handbook as our ethos and culture is not to be in the book or in the head. It has to be done in real life. UNIMED is Nigeria's first medical and health sciences university. And if we don't do unique things, anybody who is here, who is not innovative and doing good things, and knowing to work with others in other disciplines happily, that person is a yo-yo. I was talking to one person when I was sitting here since 9:45, that he's on the list too because he has learned to work with other disciplines. Our next lecture of this type will be given by Rosangela Moba. She was supposed to give this one and Leroy after, but she opted to wait. I have known her since master's degree, doctoral degree, because even though she teaches in zoology in UI, he was researching on antibodies or antigens for the development of malaria vaccine. So they come to Igbora, where I was the longest serving director of the Barakwa program of the University of Ibadan. The kind of thing we want to do the senior type here. And we have achieved it in Okegbo Ward 7. Everybody there is living at the maximum level of health that is possible for the person, irrespective of having any chronic illness. That's what community medicine is. And there will be no community medicine if there is no community nurse midwife, to demonstrate how these two disciplines and professions relate in real life. So this lecture is for people who have learned to work interdisciplinarily. I'm a public health physician, but with her, I've been a molecular biologist, I've been a quasi-immunologist because of our work. Leroy Edozian came to Ibadan to read medicine, and I've known him since undergraduate, postgraduate, and residency. Then he went to the UK and added law into it to the highest level, and is combining the two professions in the way that medicine will benefit maximally. Litigation is everywhere, so doctors who don't learn how to practice safely will be in trouble. And this is the tapestry that he'll be explaining to us today, the kind of work. I would like to leave it here that the University of Medical Sciences Postgraduate School Interdisciplinary Discourse is for people who are not building ivory towers for themselves, only me, or want to be on top of everybody's head. They learn to research with others. At Ibadan, even though I'm retired 5 years, I belong to 2 research teams in Ibadan. One is on psycho-oncology. Fortunately, my wife is the PI of that research team. I also belong to a team that is researching prostate cancer in men of African descent. Dr. Pelumi Adebiyi, one of my proteges, is the PI of that body. And they're all internationally functional. I serve on both teams, the other one as the elderly epidemiologist, because Pelumi Adebiyi is not only a population and clinical epidemiologist, He is currently the president of the International Epidemiological Association. That's a crown for Nigeria. So he's a PI, but he's an epidemiologist. So to be there must be because I'm a grandfather epidemiologist, and this is my son, carrying me around. The same way in November this year, I'm going to follow my wife to go and be inaugurated as president of the International Psycho-Oncology Association. So, what are we saying? Let interdisciplinary discourse tell you what you should be doing here. You must belong to research teams. You must learn how to work with other people where the input of everybody is respected and honored. So that is what this culture is. If you don't aspire to be one of the lecturers, please leave the university. Thank you very much.
Please let's appreciate Professor Azuzu one more time. You know, one thing, a lot of wisdom comes with age. And when you go to our elderly people, they have nothing to fear. They tell you the truth. They say it as it is. And he has advised us, particularly the academics, don't work in silos. Belong to as many groups as possible. Let your work cut across. Okay, that's the only way we can have the kind of development we desire in our society, which is development that is sustainable. Thank you very much, sir. We appreciate you. Please a round of applause for him. Okay. While Prof was still talking to us, I observed that the acting registrar also came in, so we recognize her again. Mrs. Atunwa, the acting registrar. Please a round of applause for her. She came in. We also have in this auditorium this morning, Dr. Ife Oluwayimika Bamidele. He is of the College of Law, Afe Babalola University, and Faculty of Health, Law, and Humanities, UNIMED. He's a visiting associate professor at UNIMED. You are welcome. I'm also told that part of the celebration that the landlord of Baba Azuzu is also here to celebrate Baba as Baba lives. I recognize this morning Mrs. Veronica Adekoya. Please a round of applause. Right now, I want to call on the Vice Chancellor of this university, Professor Ebun Oluwa Aderonke Adejuyibe, a professor of pediatrics and child health, and fellow Nigerian Academy of Medicine, ably represented here this morning by no other person than the Deputy Vice Chancellor of Academics, Professor Rose Angela Umuba, to give a speech. Please a round of applause for her.
Good morning, everybody. The guest speaker, Professor Leroy Adezin, the acting registrar, other principal officers of this university, deans of faculties, head of departments, directors and coordinators of centers and units, distinguished professors, academic colleagues, esteemed postgraduate students, and undergraduate students that are here present, ladies and gentlemen. It is my honor and pleasure to warmly welcome you all on behalf of the Vice Chancellor, Professor Obunoluwa Adejuyibe, to this significant academic event, marking the third postgraduate school Interdisciplinary Discourse lecture series of the University of Medical Sciences, Ondo. Today's gathering further highlights our university's strong dedication to foster a vibrant intellectual community and encouraging scholarly collaborations across disciplines, as the Dean Postgraduate School had earlier said. This lecture series is more than just a platform for academic conversation. It is a deliberate effort to promote critical cross-disciplinary thinking that addresses complex real-world problems. We are especially honored and privileged to have Professor Leroy Odezin, an esteemed scholar and a distinguished leader, to deliver today's lecture on the topic scientific, psychological, and legal correlates to patient safety. Professor Odezin, who is the acting dean for the Faculty of Health, Law, and Humanities, offers a rich mix of clinical, legal, humanistic insights, all of which are essential to the complex subject of patient safety. Patient safety remains a cornerstone of quality healthcare delivery, yet it is an area that demands holistic understanding, one that integrates scientific rigor, psychological insight, and legal accountability. So I'm wondering why most medical doctors in our hospital, UNTH, is not here. I expected to see most of them in this interdisciplinary discourse because it pertains to patient safety. So I don't know, the organizers, were they not invited? That's a mistake. The topic of this lecture is therefore timely and resonates strongly with our institutional vision of producing not only clinically competent, but also ethically grounded and socially responsible health professionals. We anticipate that this discourse will not only expand our academic horizons, but will also challenge us to rethink how we educate, legislate, and practice in ways that protect the dignity, safety, and well-being of every patient. It will particularly enrich our postgraduate community by modeling new interdisciplinary inquiries and will produce solutions to some of the most persistent healthcare concerns. Once again, I warmly welcome our guest lecturer, distinguished participants, and members of the university community to this important intellectual engagement. I encourage us to participate actively in this discourse, and I wish you all a rewarding and enlightening experience. Long live the University of Medical Sciences, Ondo City. Like we said in our in our university anthem, Hail Unimed. We'll live to see a greater future in this university. In Jesus' name.
Thank you very much, Ma. In a way, that speech has given us an idea of what we stand to benefit from the lecture. And I hope we are ready. Please sit down very well. Ensure you fasten your belt. The plane is about to take off. And I want to respectfully call the lecturer for today to please stand and come towards the lectern here as I read his brief citation. Professor Leroy Odezin holds degrees in basic medical sciences medicine, and law from the universities of Ibadan, London, and Glasgow, and specialist qualifications in obstetrics and gynecology from the West African, UK, and Irish postgraduate medical colleges. He served as Director of Clinical Governance, providing strategic leadership on patient safety across 5 teaching hospitals in Manchester. He undertook assignments pertaining to clinical standards and safety for the UK National Patient Safety Agency, the UK National Institute for Clinical and Health Excellence, and the Royal College of Obstetricians and Gynecologists. Professor Edozen has published extensively on clinical governance and delivered lectures on patient safety in South Africa, Ghana, Egypt, Brazil, Canada, South Korea, Estonia, Ireland, and the United Kingdom. He is currently the convener of the Health Law Program at the University of Medical Sciences, Ondo, which has graduated 2 sets of MSc students and currently has 6 PhD students. Distinguished ladies and gentlemen, I present to us a cerebral scholar, Professor Leroy Edozen. And please, very important, let's take this seriously. Please put your phones on silence, or possibly you put the airplane mode on for the purpose of this lecture, after which you can put it on. Thank you.
The Vice Chancellor will be represented by the DVC academic, Professor Nwuba. Professor Nwuba, in your own rights, as the Deputy Vice Chancellor, academic, and my boss, principal officers of the university, the Dean of the Postgraduate School, the Chairman, Committee of Deans and other Deans, HODs and directors, colleagues, students, ladies and gentlemen. As you have heard, the Postgraduate Interdisciplinary Discourse Series is intended to provide a platform for exploring themes that cut across disciplines and also to encourage collaboration amongst academics in various disciplines within and outside the university. My presentation today has its roots in clinical practice because it addresses something that is so central to what we do as clinicians, and that is patient safety. However, it draws from a range of disciplines, including behavioral psychology, cognitive neuroscience, health system science, and law. When I was a resident doctor, I experienced a patient safety incident that had a profound impact on me. A colleague picked up a vial of what was supposed to be Depo-Provera, which is a progestogen we use to treat things like menstrual disorder, and injected it into the patient. Lo and behold, it turns out it was not Depo-Provera, it was heparin. You can imagine the effect. Heparin is an anticoagulant, so you have massive internal bleeding, and if you have any wound anywhere, external bleeding. It was disastrous. There's a parallel between that one and this one. This is Bob East, a celebrated photographer in Miami. And he went for an operation on his right eye because he had a cancer there. as part of the operation, it was necessary to withdraw some cerebrospinal fluid from the back there to reduce the pressure during the operation, okay? And it's their custom that at the end of the operation, that CSF, cerebrospinal fluid, is injected back into the patient. Now, the specimen for that operation had to be taken to the research laboratory in the next building. So somebody from the laboratory came with a container containing glutaraldehyde, okay, which is similar to formaldehyde that we use in the anatomy lab. That was for the purpose of preserving the specimen. So you take the specimen out, put it there, and they take it to the laboratory. So many things happened. And then at the end of the operation, the anesthetist picked up what he thought was cerebrospinal fluid and injected it. And it was not CSF. Do you know what happens when you put tissue inside formalin? That is what happened to his brain. Automatically, he was brain dead. The surgeon who attended to him came out openly and said it happened as a result of, oh, you can't see this clearly, sorry. Is there a way we can do this so that they see the slides properly? Otherwise, this presentation would make no sense. Yes. Okay. So the surgeon said to everybody, said to the world, said to the press, sorry, this happened as a result of a tragic series of human errors. I put that in bold because I want to draw your attention to one thing. Series. It wasn't just one person's error. It was a series of errors. It is what we call an error chain. That anesthetist just happened to be at the end of the error chain. In smaller letters, I have put what one of the newspaper editorials said at the time. He said, if this man had not been well known, would it have had all this publicity? Would there have been all this disclosure? Or would it be that they would have tried to conceal it and hide it? We shall come back to that later in this presentation. This is another case, the case of Mrs. Sarah Yu. This woman had a diagnosis made and she underwent mastectomy for breast cancer. She had 8 rounds or courses of chemotherapy. She had 25 sessions of radiotherapy. It was only after all this it was found out she did not have breast cancer. There was an error in diagnosis. And by the way, she was still crying out for what? Justice. I was invited by the coroner in Belfast, that's Northern Ireland, to be an expert witness in a case that appeared in court there. And this was a case where a professor of gynecology was performing an operation on a young lady. I think she was in her 30s. She had a bit of irregular menstrual bleeding. And they said to her, oh, you have a little fibroid inside. Just come in, we'll pass a camera to see the inside of your womb, excise this little fibroid, and you go home the same day. Or we call that outpatient hysteroscopy. Come in, have it done, later in the evening you go home. You can see from the Belfast newspaper reports what happened. Within 10 minutes of the operation beginning, things had to go wrong. She was bleeding heavily. The surgeon's attention was completely on stopping that bleeding. He tried. She was bleeding. Take note, his attention was on the bleeding. He was fixated on the bleeding. Now, the inside of a woman's womb is not, the front and back walls are not closed like this. Okay? For you to see the inside, what we normally do is we pass in some fluid into the womb to distend it so you can actually see inside and take away the fibroid. That fluid that we use is hypotonic fluid. As it's going in, we are measuring how much is going in and how much is coming out. So we make sure that we collect as much as we put in. Otherwise, a lot of it will go into the woman's circulation and she will have fluid overload. If it's overload with saline, it's not bad. It's not good, but it's not too bad. But if it is overload with glycine, the woman becomes hyponatremic. That means very low sodium. You have cerebral edema. You have heart attack. In this particular case, a lot of the water was going on the floor. And they are putting more water, and more water. When he got to the coroner, and the coroner is like a court, it seems like a judge, and you have, witnesses. And they asked people, nurse, what happened? He said, we knew that this water was too much and all that, and we told the surgeon. They said, what did the surgeon do when you told him? He said, he just nodded. Okay. What has happened there is that surgeon, he's hearing, but he's not hearing. Okay? What you have to do in that situation is what we call a timeout. You call a timeout. Everybody stop for a few seconds. There's something wrong going on here. You have a runner, somebody who goes and brings things for the nurse. Go and bring water. Go and bring this. Go and bring that instrument. That lady said, she was asking, we don't normally use up to 9 bags of water for this thing. We only use 1, 2, maximum 3. Now how come we are using 9? But you know what? She wasn't bold enough to speak out. She wasn't bold enough to speak out. Anyway, even the anesthetist who was supposed to be monitoring what was going on, the next thing he knew, the woman had had a heart attack. She died on the operating table. Talking about speaking out, we had a case where the wrong kidney was removed. The man had one diseased kidney that was to be removed. He went into theater, they removed the good kidney. And when you are saying, let me make you say another big Why? Because a medical student then knew they were doing the wrong thing. If he had the courage to speak out, not to whisper to somebody, but to whisper, say, hang on. Okay, but our culture did not allow that. It is not only in surgery that you have errors. Here are 2 publications that discuss error in physiotherapy. Okay, so you can go and look them up. And they're asking, these errors in physiotherapy, are they errors that are preventable? And what can we do? So they give some guidance here on what can be done. So one on the left, one on the right. These are 2 separate publications. That's physiotherapy. In nursing, I've also picked out 2 publications. There are so many others. Okay? So in whatever area you are practicing, this lecture applies to you. Laboratory science. Again, you can have errors happening before the sample gets to the laboratory. That's pre-analytical. Things like errors in collection, in labeling, in transportation. When it gets to the laboratory, errors in analysis. And then after it has been analyzed, errors in interpretation and so on. For example, in the case of the breast cancer that I talked about. So there's a whole range of errors that could happen and consequences of such error. Medication error, patient misidentification. As a result of that misidentification, they get the wrong treatment, complications arise. Blood transfusion error, you give them the wrong blood group, or so you give some A, the blood that was meant for B. Errors in diagnosis, errors during operations, wrong site surgery, which means you are supposed to operate on the right eye, you go and operate on the left. You are supposed to operate on the right hip, you go and operate on the left. It has happened. You need hip replacement here, but they go and do it there. Healthcare associated infection. You go into a hospital without an infection, and you live with an infection that has been acquired in course of your treatment. And then unrecognized deterioration. So this patient's condition is deteriorating, it's going down, it's going down. People have not noticed. Or if they have noticed, they have not acted quickly on it. Let's take one of them, medication error. This is a publication from this country. It's a national survey. And you will see that it included doctors, nurses, pharmacists. Okay? Over 2,000 of them. And 47%, that's roughly half, admitted that they had had a medication error. Nearly half of the people surveyed said at some time or the other they have been involved in a medication error. That is serious. Should we be doing something about that? Yes. Talking about medication errors, this is what a cartoonist came up with. Okay? And that's the senior doctor saying to the junior one, what you can read at the bottom there is, but I told you to give him 2 micrograms of insulin, not milligrams. You better start thinking of a family-friendly way of explaining his death. So they have mistaken milligram for microgram. Communication error. Wrong mental model. But see what he's also saying to the junior doctor, to find a family-friendly way. Find a way that you'll explain to the family why they died. We shall come back to that shortly. The Punch newspaper, they describe this as a harvest of errors. You know what that means? That means there are so many of them. It's like at the end of the rainy season, you know, when you do your harvest, your farm is full. And it says that our private and public hospitals, that's the one I have labeled in red circle there, that we are error prone. The newspaper that you're the journalists recognize that in hospitals we are error prone. We, the practitioners in those hospitals, do we recognize that we are error prone? I don't think so. In that same report, they talked about Mrs. Idiat Oseni, which is not her real name, that she complained that a doctor forgot a cotton pad in her womb when she had the baby at General Hospital. Okay? Which is the same as Mr. Isaac Oluyi was saying at the beginning of this presentation. And there are so many other cases like that. Okay? So that harvest, what is the scale of it? The epidemiology of patient safety incidents is astounding and yet grossly underappreciated. Studies in Australia, Canada, UK, United States, all of these have come to basically a consensus that 1 in every 10 patients is harmed as a result of what we do. 1 in 10. And if you look at that globally, that's a lot. And we are saying that about 3 million deaths happen all over the world every year as a result of error in clinical practice. 3 million deaths. Now, apart from those deaths, you also have people who survived, but as a result of the complication, they need more treatment. You are now treating what they came in with, you are also treating the complication that you caused. Then there's the loss of work, loss of earnings, other things that go with it. All those count as the costs of patient safety incidents. Okay, and we're talking in the region of $1 trillion every year. It's okay to talk statistics, but what do they translate to in real life? Physical trauma. A wrong part of your body has been removed. You have had to go back to theater for something else, and so on. Psychological trauma for the patient, for the family, emotional distress, and of course, there are financial consequences. So at the time of our induction into our various professions, we are told, first do no harm. So how come we are actually harming many of our patients, albeit unintentionally? The fact remains is that they are harmed as a result of the care we have offered. Why is that happening? It could be due to deficits in knowledge, but it could also be due to other problems, like perceptual problems, like attention problems, like communication problems. We all know about the impact of knowledge deficit. That is the diet that is fed to us throughout our training. That is why we are required to pass exams. But we also begin to appreciate more and more the importance of effective communication. But we pay very little attention to the other sources of error, perception and attention. And those are things that we're talking about in the next few minutes. If we want to reduce harm as a result of our care, we must have what is called safety wisdom. We must be safety wise. Because safety doesn't just happen. It's not a thing that happens by chance. We actually have to create that safety. And we must have the cognitive skills to be able to do so. Those cognitive skills are part of the non-technical skills that are very important for all health professionals. Regrettably, all the emphasis, or nearly all the emphasis, is on technical skills. And what we're saying this morning is, please, technical skills very important, but non-technical skills just as important. The two go hand in hand. They are not separate silos. They should be bridged as reflected here. What are those non-technical skills? Leadership, decision-making, communication, teamwork, situational awareness. I've put situational awareness in bold because that's the one I want to focus on next. So what is situational awareness? Situational awareness is simply being aware of what is happening around you, gathering that information understanding it, and then using it to project what is likely to happen. That's what situational awareness is about. So, I hope you can manage to make out this diagram. It's taken from one of my publications. And basically, it's saying that you have environmental cues. Sorry, our laser is not working. Environmental cues, what is happening around you. You use that to sustain situational awareness. If you are situationally aware, you make the right decisions, your performance is optimal. If you lose situational awareness, wrong decision making, below par performance, often resulting in error, and that error could also result in harm. But what are the things that could impact on situational awareness? They are listed there. Communication, coordination, fatigue, memory, task saturation, blind following of protocols, lack of briefing or debriefing, attention problems. Now, to understand situational awareness better, it's important to also know about two things that I'm going to talk about briefly. One of them is working memory, and the other one is mental model. Let's take working memory. When you gather information from outside and it goes into your brain, it goes into these buckets where it is processed. Some of that may be transferred to long-term memory. Long-term memory is vast. It can contain a lot. Short-term memory has limited capacity. So you can find that somebody comes from the United States or wherever, they come back to Ondo City. They've not been around for 3 decades, but they can still find their way around the town. They can even say, this place has changed. Oh, that building wasn't there, because they remember. All that is coming from long-term memory. But that same person who can remember all these things, maybe they have promised so many people, Adeshego, and so on. Then suddenly, Ademilu, he says, you said you are going to come and see me. Oh, I forgot. How come they remember their way around, but they couldn't remember? Because that one is in short-term memory. So short-term memory, when there's too much in it, you lose some aspect, you forget some aspects. And that is what often happens in clinical practice. So this case, for example, the doctor comes, sees this child, orders some tests, and says, I will come back within the hour to review the results and see how the child is doing. But they are busy. They are dragging them in A&E, in what this, in that. Consultant is ringing, go and see this patient. In the process, they have forgotten that they are supposed to come and see this patient within an hour. And that patient collapses. And we have had cases like this where the patient actually dies. Who gets blamed? The doctor or other health professional who is involved. It's not accepted as an excuse that the system was so rubbish that they were multitasked, did not have enough support, etc. So the next one, as I said, is your mental model. Your mental model is what is going on in your head. How do you see what is happening outside? What is your own interpretation? What's your knowledge? Everything you think about what is happening around you. It may be consistent with what is happening. On the other hand, it could be different. And what's in your head, what you are thinking, is not in consonance with the reality. Okay? But what you have in your head is your mental model. And it's affected by your beliefs, your preconceptions, and so on. It could also be affected by what we call automaticity. So, as a result of faults in the system, as a result of some operator, that's the individual practitioner, their attributes, they may have the wrong mental model. And that is a recipe for error and accidents. I use this quite often here in UNIMED and elsewhere when I'm teaching our students about mental model, okay? Because when I put this up and I say, what is this? What I am told, if I'm wrong, correct me, this is a diagram of a female anatomy, correct? No. You know? So almost everybody says, you know, it is. In fact, I belonged to an executive committee of an international body. And for, you know, as an exercise, I sent this to members of the executive committee. And some of them replied to me, Leroy, why are you being so vulgar? And then I point out, I say, hang on, it is not a female anatomy. It is a diagram of two stick dancers. One here, one there. And they are just dancing, you know? See? So look at it again. There are two stick dancers. Their arms are up, you know, and the head and the legs. Okay? So that, if you know. Okay. So, can you now see that we are all vulnerable to having the wrong mental model? If this were a clinical scenario, all of you are in trouble. And talking about real clinical scenarios, I took this with my phone camera. You know, I always carry cheap phones, so that's why it didn't come out sharply. So on the labor ward, I was about to conduct a repair, perineal repair, for a woman who had tear in labor. Okay? So I've sat down ready to start. The midwife picks up local anesthetic, which I asked for. She breaks it, and if you look, you may not see too clearly, but this one on the left, it's actually broken at the top. She broke it, drew it in a syringe, so she now brought it to me to draw it. Okay? And we do what we call double witnessing. So she has looked at it, checked it, the name and the expiry date, and she'll give it to me to look at to confirm the name and the expiry date. Lo and behold, I say, this is not lignocaine, no. This is fentanyl. Fentanyl is a controlled drug. It should not be in that room. Point. Time out. What's going on here? We now looked at the package. You see, she took it from a pack that has lignocaine in it. Somebody has now returned that bupivacaine and fentanyl into that box. Almost everything identical to lignocaine. So that's a design flaw. Number two, controlled drug. Somebody, when you take it from the controlled drug cupboard, you sign for it. When you return it, you sign for it. Who signed for it, or did they not sign? And then they left it in the room, that room, and when they were cleaning the room, what happened? Nobody took notice of this. The midwife who went there, she just picked it, you know, in her brain. She's taking it from lidocaine package, so it must be lidocaine. So even though she's looking at it, her brain is telling her that is what we call confirmation bias. Okay? That there's a whole range of things called cognitive biases, and this is one of them. You know, you see what you are expecting to see. Okay, that's so her mental model was wrong. But she's only an inheritor of the pathogens in the system. Okay? Because you can see it was a chain of error. So we are back to that thing we're talking about, chain of error. Apart from individuals maintaining situational awareness, teams also have to maintain situational awareness. There must be shared mental model In other words, I can't have my own mental model different from that of Medu and different from that of Lagbaja if we are working as a team aiming to achieve the same objective. No, our mental model must be the same. And I just put together this diagram, picture, infographic, whatever I want to call it, where people are misinterpreting the road sign. Okay? The road sign is constant. It's not changing. But our attitude to it, our interpretation to it varies from one person to the other. So in this case, Abu was reading it correctly, but did not communicate what he was reading to the other people. Medu was misinterpreting it. Lagbaja just ignored it. Okay, like we do to traffic lights and road signs in this country. And of course, Didi was just thinking of a different route altogether. His attention wasn't on that one. Okay, so this is a dysfunctional team. They don't have shared mental model. For the road sign there, you can substitute clinical guideline, protocols, whatever. So how do we try to promote that shared mental model? Okay, I can't go into details of this. Here is one book or booklet you can read. I'll put the website there. You can look at it. It tells you some of the things that can be done. Structured communication means that there is a structure to how you communicate amongst yourself. If I'm a consultant at home and somebody says, somebody has come in, well, I'll use gynecology terms, So she's come in, she's 36 weeks pregnant. She's had some bleeding. We have admitted her, and she's still continuing to bleed. I'm now waiting for them to tell me, hey, so what? Okay? And I said to them, no. You use structured communication. For example, SBAR, situation, background, assessment, then recommendation or request. What's the situation? She's a woman, first pregnancy, 36 weeks pregnant, everything normal so far. Okay? Assessment, she has come in with heavy menstrual bleeding. She has lost 1 liter of blood. And her pulse rate is so-and-so, her BP is so-and-so. Okay? Recommendation, I would like you to come in, sir, because she may need to go to theater and have some other decisions. Then I know, okay, they want me to come into hospital at 2 a.m. for that. Okay, that's a structured communication. The same thing applies to handover. The other thing is also about reviews. Anytime you're in especially acute care, you are constantly reviewing. You review. Where I worked, we used to do ward round at 8 o'clock. We do it at lunchtime. We do it at 5 p.m. We do it at 8 p.m. Constantly reviewing. And then what you have, read back. And the best example I can give you of read back is when you order something. They may not be doing it at Iyaojo, but they'll be doing it in places like Chicken Republic and so on. When you place an order, after you place an order, they read it back to you. You've ordered, 1 pomo, 10 goat meat, 1 this, and then you agree that that is what you have ordered. We should be doing more of that in our communication in medicine. Then automaticity, which is another factor, as I pointed out to you, that affects situational awareness. Many times we're on autopilot, but we don't know that we are in clinical practice. It's a common source of error. Now look at automaticity. When you are walking from here to your car, you are not thinking about it. It's automatic. But that is a conscious automaticity because you consciously decide, I'm going to go to my car. Okay? That is a good way that nature uses to preserve your attentional resources, where you are doing it but not consciously. It usually applies in cases where you are doing a task repeatedly. You've done it so many times that it now just becomes like automatic to you. Okay? So that's what often happens in these cases of retained swab. Okay? Because normally at the end of the operation, you should count your swabs. You have counted them before, and you count them after. But because our staff are used to counting, no. Swab count complete, instrument count complete. Okay, when you go back, as we have done many times, and go and look at the records, it says the count was complete. But actually it wasn't. If it was complete, how come there's a pair of scissors in the person's stomach? Or how come there was a swab left in the vagina or inside the womb? Similarly, in IVF treatment, they used to mix up embryos. A couple come for treatment, they carry the embryo or the eggs or the sperm and give them. Okay? It caused them to have a baby that is not theirs. You'll find a black couple having a white baby. You know? So because of that, they decided to introduce what is called double witnessing in IVF. So when you're an embryologist, dealing with eggs, sperm, embryos, you will call another embryologist to come and confirm that actually these ones belong to Maria and not to Mary. Okay? So, double witnessing. Having said that, even with double witnessing, occasionally you still have mistakes, okay, errors. So, yes, it reduces it, but it does not reduce it to zero. Related to all this is what is called inattentional blindness. You are looking, but you are not seeing. Okay, somebody comes through the door here. They are looking for where to sit. And where is the free seat? Okay. Professor Nick Bide might be waving. Professor Nkinku, I'm here. He doesn't see that person. Why? Because their attention is on looking for a chair. It happened to me last week. I was flying from Asaba to Abuja. I sat. Somebody that I know very well, he knows me very well, came in. He was looking at the cabin something for the number of his seat. He was there. As he was coming, I said, this man hasn't seen me. I was looking at him. My eyes were pointed at him like an arrow. He didn't see me. As it so happened, his seat was also my row, just that he was on the other side of the aisle. It was only when he sat down, he said, Ubili, you are here. So that is inattentional blindness. Okay? So, some of these have been demonstrated amongst neurosurgeons, amongst radiologists, amongst obstetricians, gynecologists, and so on. And these experiments and real-life situations are actually in the literature. You can go and find them. In one case, they gave they asked the people looking at slides in pathology to look for a small nodular growth under the microscope. And within those slides, they put in a gorilla. About 6 in 10 of the radiologists did not see the gorilla. These are specialists. And they tried it with non-physicians. It was almost 100%. In a similar experiment, they gave them to look at something in the lungs. Okay? But within those images, there was also a breast mass, so enlarged breast. Because they were being told to look for a nodule in the breast, they did not see the breast mass. And of course, the breast mass in the image will be outside, the rib cage. So they're focusing on, what's inside. They did not see the bigger picture. That is inattentional blindness. So all those things lead to errors. They could explain errors like the one we saw of Mrs. Sarah Yu. Okay? It could also be responsible for what we call failure to rescue. What is failure to rescue? Failure to rescue is when somebody's condition is deteriorating, is going down, going down, going down. When are they going to intervene? When are they going to intervene? Nothing is happening. Nothing is happening. I was involved in preparing this report for the UK National Patient Safety Agency. And these are the three main things that were happening. First of all, for a prolonged period, no observations were made. Or observations were made, but no action was taken, or the deterioration was not recognized. How did you not recognize it? The pulse rate was going up, the BP was coming down. And of course, delay, even when that deterioration has been recognized. All those things are called failure to rescue. If I go to a typical Nigerian intensive care unit, emergency unit, etc., and I ask them, what is failure to rescue? How many of them will be able to tell me what failure to rescue is? And yet, failure to rescue is an established term in patient safety literature. This lady was a chef, celebrated chef in Lagos, Peju Uboma. She had fibroids, went for hysterectomy in a Lagos hospital. Operation has been done, everything's finished. She's gone to recovery. You know, she was bleeding inside. If you are bleeding inside, it will be reflected in your pulse rate. It will be reflected in your blood pressure. It may be reflected in the soaking of the dressing on your wound. But even blood pressure and pulse rate, respiratory rate, these are enough to make that clinical diagnosis. You don't need rocket science. But it was not recognized, and she died. Go and Google Peju Uboma. You'll see lots of newspaper stories on this case. Okay? This is not a personal picture of mine. It is from the internet. It's from newspapers. Why? Failure to rescue. Failure to rescue because either they did not monitor her vital signs, or they were monitored but not recorded, or they were recorded but not properly interpreted, or they were properly interpreted and no action was taken, or a combination of all of these. And she's not an isolated case. It happens all the time. When we talk of patient safety, we often look for lessons in sectors where safety is taken of so much a priority that they have significantly reduced the rate of accidents. For example, in the case of nuclear reactors and nuclear facilities, because if you have an accident there, boom, the consequences are unimaginable. Okay? Similarly, in aviation, and we have a lot to learn from the aviation sector. Although I must emphasize one big difference. In the aviation sector, if something goes wrong, the pilot dies. In the health sector, patient dies, the others are having their beer. Okay, what can we learn from this accident? In aviation, there's something they call controlled flight into terrain. What it simply means is the aircraft is perfectly okay. There's no fault with it. But somehow the pilot manages to go and crash into a mountain or into a valley or into the sea. Nothing to do with technical aspects of the aircraft. It is just pilot error. This plane was carrying the president of Poland, his wife, the chief of air staff, chief protocol officer, chief of army staff, top politicians, and so on. Almost the whole hierarchy of Poland. They were flying to a part of Russia called Smolensk. In that place, 70 years earlier, there had been a massacre of Polish people. So they are going for the 70th anniversary. That is why it was such a high-powered team. Smolensk is a small airport or airstrip, actually a military airstrip, very small. So the navigational equipment there were below what you normally have. The person there doing the air traffic control only speaks Russian. The international language for that is English, but in this case, he could only speak Russian. On the plane, the only person who could speak Russian was the pilot, the captain. Normally, one person will be flying the plane, the other will be doing navigation. In this case, he had to do both the flying and the navigation. Okay? Multitask, which we have talked about earlier. Okay? Then, there's another member of the presidential fleet who had flown the president on a previous flight. And when they are about to take off, the president said, sorry, we are not going to Akure anymore. Please, we have to go to Ilorin. And the pilot said, I'm sorry, sir, we can't do that. We have already had a flight plan. We are on the verge of taking off. I can't even remember the details. Maybe they have even, gone off the runway. He said, sorry, we have to go and land in Akure. And because of that, they removed him from this flight. They removed him from this flight. Now, the pilot of this flight, the captain, he had been told by the people on ground that the weather is not good. The advance party who went before, the president, they don't just go like that. Somebody has to go in front. The advanced aircraft, they told him that we had some difficulty, but we managed to land. Everything favored making a decision that we have to go back. But waiting then go tell Oga, and all the Ogas were there. That means, you can't even fly simple to land, you can't do it. Other people have landed before us. Why is your own different? The chief of air staff and the protocol officer, they entered the pilot's cockpit. So they were under pressure. So all this I put there about hierarchy, about clash of motives. I can go in other details about that flight, but everything was just, that chain of error we're talking about was operating. And so they tried to land and they ended up crashing. All those things, you see them in clinical practice. Multitasking, heavy workload, inappropriate for the situation, divided attention, okay? Wrong decision making, violations, this hierarchical thing, and of course, clash of motives. So, we've got to take some action. We have to reduce distraction. We have to reduce multitasking. We have to introduce double witnessing. We have to have proper protocols for handover. We have to beware of cognitive biases. I mentioned one of them, the confirmation bias. The other one is halo effect. There are so many of them. But you could see halo effects when they are afraid because the Oga was there. What will he say? Sometimes we are afraid, like the medical student I told you about, did not feel empowered to tell Oga, look, you are removing the wrong kidney. Mental fitness, cross-check, double checks, memory joggers. I worked with somebody, when she says, I'm coming back to review this trace or review this, she will set her phone alarm. Okay? So the alarm will ring. Say, I have to go back and see that patient, and so on. One of the ways of maintaining situational awareness is the use of checklists. And in medical practice, clinical practice, perhaps the best recognized and perhaps the best successful checklist is the surgical safety checklist that was introduced by the World Health Organization. It was introduced after a random control trial, and you can see the paper on the extreme right there. The countries in which this was done included I think Ghana, South Africa, and so on. It included some countries in low and middle income. So it's not just something for the United States. It's global, okay? So it applies across the globe. And this has been demonstrated to reduce mortality and morbidity. The evidence is there. It works. In the face of opposition. Even before the WHO came out with it, I had introduced it in our own system in Manchester. And I had to overcome opposition to introduce it. I had to go to the surgeons' meeting to talk to them and even threaten that if people don't go follow it, we shall report them to the General Medical Council. But now it is well accepted all over the world. As a result of that surgical safety checklist, the practice was introduced whereby if you want to operate on the left side, you mark the left side. If it's the left, right hip or whatever, you have to mark the site of your operation so that we reduce the chance that it will be wrong site surgery. Okay? So that's part of the things in the checklist. They'll say, have you marked it? But as I said earlier, there's no guarantee that even all your precautions will prevent error from happening. It will reduce it. It could even reduce it substantially, but it almost never reduces it to zero. Okay? And this is a cartoonist trying to illustrate that. He said, okay, look. Okay, the surgeons look at it. They said, the leg has been marked. This is the leg that we want to amputate. Okay? And after they have amputated it, okay? Okay? So, the people who are supposed to marking, they have done the marking, okay? On the ward, though, they do the marking on the ward, okay? But when the person gets to theater, the nurse who is prepping the patient puts the drape or the doctor sometimes, and then they have covered that side of it, Okay, so you find that, right? So the traditional approach to patient safety was that we blame the person who has committed that error, okay? That is the culture of blame, okay? But as things began to evolve, we said, okay, no, these people are inheriting pathogens from the system. Let us focus more on the system approach. But the problem with the system approach is maybe to encourage people not to take responsibility for their actions. You say, oh, it's not my fault, it was the fault of the system. So we said there has to be a balance. This is a case that illustrates the blame culture. Dr. Hadiza Bawa-Garba. I can't tell you the details, but they are all available on the internet. Okay? Her consultant said she was working in a perfect storm. All these issues about multitasking, about this and that, she had just come back from maternity leave, there was post supervision and so on. Okay? And then she was taken to court and she was convicted for manslaughter. Okay? Gross negligence manslaughter. And there was a big hullabaloo about it. After how many years? She was finally exonerated. And her suspension, she was allowed to go back to practice to finish her training and so on. She was a registrar when this happened. A good example of blame culture, and what came to our rescue was the system approach. Okay? So this is something you find in most risk management conferences. What we're saying is that the system defenses are like Swiss cheese. They have holes in them. And sometimes those holes line up. So you have that error chain unfolding. And ideally, there should be somebody who stops that error chain, okay, before it becomes an accident. But that person has to have the right cognitive skills, okay, which is what we have been talking about. Okay? As an alternative to the person approach and the system approach, I proposed a bionomic approach. which is a published paper. And the bionomic approach, I'm saying, look, in the systems approach, we are taking lessons from engineering, from the aviation sector and so on. But in those places, okay, they are looking for zero error. Okay? Whereas in the health sector, okay, it's so complex, there are so many interrelationships, there's human factors, and so on. So we should be looking not to engineering, but to ecology to get our paradigms. Okay? So bionomic approach, there's a lot of it in the literature, you can read it. All of those considerations have led to the emergence of a third science in health sector, and that is health system science. So traditionally we have basic clinical sciences, basic medical sciences, we have clinical sciences. That's what medical education is all about. We are saying, no, there is a third pillar now, and that pillar is health system science. Okay? And these three, they are not independent silos. They have to work together. It should be reflected in our in our medical education and in the way we deliver services. Okay? So based on that idea that health is a complex adaptive system, we began to look at the frameworks used to promote patient safety. This is the one by the UK National Patients Agency, and it talks about 7 steps to patient safety. So it is linear, okay? This is the one from Australia. Again, it's having different domains. It's also linear, okay? All these are linear because that's how we are brought up, the biomedical model, cause and effect, okay? This is the one from the United States, IHI, okay? Again, we're now beginning to see a move away from linear to something more integrative. However, this framework does not include many things. There are some elements that are not here. I have no time for us to go into detail, okay? So I came up with my own framework, which is the RADICAL framework. And RADICAL is an acronym for Raise Awareness, Apply Quality Improvement Methods, Design for Safety, Involve Service Users, Collect and Analyze Data, and then learn from patient safety incidents, okay? And that is the framework as it should be represented, okay? Showing that each domain informs the other domain and is informed by other domains. Okay? This framework has been used in some places as the basis for their clinical governance activities. Let's move now to the legal aspects of patient safety. Okay. One of the ways the law has sought to promote patient safety is through regulation of the health professionals. Okay. Initially, it was self-regulation. That means the health professionals regulated themselves. But we can't move away from that. Say, look, if they are self-regulating, patient safety may be relegated. They may close ranks. So the more modern way is some form of external regulation, usually a hybrid, so that it combines both health professionals and people outside. Okay. The other change in regulation of health professionals is that traditionally it was about punishment. The regulators are there to punish erring doctors, nurses, midwives, etc. But now they are doing that, but they're also using their regulatory powers to promote establishment of standards and to promote learning. The other aspect of legal dimension of patient safety is in relation to litigation. Because when something goes wrong, that's the first thing everybody thinks about. The patient thinks about it, the doctors, nurses, etc., they also think, am I going to be sued? The classical case used to be that of Bolam, where it was decided that, look, so long as you have complied with a reasonable body of opinion in your specialty, in your discipline, that you are covered. Okay? So not everybody has to agree with what you have done. But once you have a reasonable body, the court will say, okay, that's all right. But in the case of Rogers and Whittaker, this woman had an operation on one eye and was worried about the good eye. If I have an operation on this one, what happens to my good eye? Will it be affected? That chance of it being affected was 1 in 14,000. She was not told. Unfortunately for her, that risk materialized, and she lost vision in that eye. So When in court, the experts came and said, 1 in 14,000, we don't usually, tell our patients this. Okay? So that favored the defendant. But the court decided, no, this one was particular about this thing. So even though the chance of its happening was very, very low, you still should have told her. So you see, they move away from Bolam into a patient-centered approach. And that patient-centered approach, this was an Australian case, was now implemented in England and Scotland, in the UK, in the case of Montgomery, where the Supreme Court decided in favor of the patient. What did the patient expect to be told? What did she want to be told? What questions did she ask? Not what the doctor said was acceptable or not acceptable. So what is the message for us? The message for us is that we must now be listening more to our patients. Okay? We must be doing more to know what their needs are, what their requests are, and so on. And of course, when we don't do that, we may end up with the disciplinary tribunal for the various professions. And more recently, there is the Federal Competition and Consumer Commission, which was set up by an act in 2018. Okay? So you could see that the right to health care can be regarded as a consumer right. And this commission showed great discuss the case. They told her, sorry, we have thrown away the specimen. They used to say that doctors bury their mistakes with their patients. Here, the pathologist buried his mistake with the specimen. So that's the woman. Still crying for justice. Also, they never apologized to her about saying sorry for what happened. Okay? So, in the UK, traditionally, all over the world, there's an ethical obligation, okay, for you to be honest with your patients. Okay, that's ethics. But now in the UK, there's a legal duty. It's called the legal duty of candor. So, if you don't comply with that duty, you have committed a crime. Okay? So, details of that duty, you can find out in the booklets, because there's no time for us to go into that. And then, in addition to that, you have apology laws in some places, notably USA and Australia. The law requires you to apologize. However, it's not so helpful to the patient in many cases. Why? Because it protects the doctor or other health professional who says, I'm sorry for what happened. It doesn't protect you for saying, I'm sorry, this is the mistake that we made. And so there are two different things. So duty of candor, you can read more about it at that website. And then what should we be doing? Clinical governance. We need to establish clinical governance. We need to look at our education and training. Okay, these are the pillars of clinical governance based on the radical framework. Clinical governance is basically everything that we do to promote quality and safety in our practice. That's clinical governance. You can go into details, but overall, that's what it is. One of the components of clinical governance is audit. So in audit, you are asking, what's our practice now? How does it compare with what should be standard? What do we need to change? Okay? And how do we learn? Okay? So all of that is captured in what we call the audit cycle. This is not rocket science. It is done all over the world, except in places like Nigeria. Then risk management, another component of clinical governance, is saying what can go wrong and what are the chances that this will happen in our unit. Okay? If it happens, what's the impact? How can we minimize the chances that this will happen? When it has happened, what lessons can we learn? What lesson can we learn from the Peju case, from the Sarah Yu case, and so on? So that's clinical governance. We don't have it here. Only one place in Calabar where they tried to do something. Okay, but it's a one-man band. Okay, we don't have it in our system. And then finally, education and training in patient safety. The WHO came up with a curriculum for patient safety training in 2011. 2011 is 14 years ago. Tell me why medical schools are not having it today. 14 years after it was put in by WHO. If you put in a lecture tomorrow here or any medical school for robotic surgery, laparoscopic surgery, recent advances in kidney, the place will be packed full. Put a lecture on patient safety, you have to go and drag people out. I have looked at CC Mass for medicine and dentistry, for pharmacy, for all of them. Yeah, nursing. You know, they don't have specific provision for patient safety training. So that's the WHO curriculum in one column. The radical framework includes everything in the WHO framework, but above all, it also includes collection and analysis of safety data. Here in UNIMED, we have introduced the teaching of patient safety and medical law into the undergraduate medical curriculum, the first in Nigeria. However, when we started, we were given 6 weeks to do the teaching. Now, we are down to 2 weeks. Okay? And my fear is that when I finish my time here in a year or two, we shall be down to 0. Okay? So combining training and clinical governance will be the way forward. So in concluding, let me say that we need law reform in Nigeria. The main law that governs healthcare delivery here is the National Health Act. The National Health Act does not specifically mention patient safety or make provisions for clinical governance. Okay? So we need to look at that act. And I would like to see the act amended to include the setting up of a commission charged with quality and safety in our healthcare facilities. They have it in other places. Okay? Under the Act, you have various agencies that are set up, but there's none set up to deal with quality issues. And safety is a key dimension of quality. And I've talked about UNIMED and our teaching hospital. These two institutions working together can make this place the focus, the champion of clinical governance across this country. Why can we not be the leader in that area? Why should we not set the path for others to follow, based on all that I have been saying? And finally, all these things we have said today, I hope they convince you that given the interdisciplinary nature of the delivery of health services, the interdisciplinary nature of medical education, that we actually need a faculty of health law and humanities. I would say that only a retrogressive mindset would say that this faculty does not deserve its place in this university. Lastly, let me thank the Dean of the Postgraduate School for giving me the opportunity to give this lecture. Thank you very much, sir. And I wish you well in your future endeavors. You once told me that you have about 5 roles or so, maybe more, in this institution. So you're only giving up one. I'm sure that you'll be continuing with all the others. I would like to thank especially the chairman of the organizing committee, Professor Teslim Munigbide. You've been fantastic, sir. I would like to thank my colleagues in the faculty, those who are with us here, and those who are visiting. For example, Professor Bamidele from Afe Babalola University. And finally, I'd like to thank all of you for coming. Thanks for being to the end. Thanks for giving me your attentive audience, and God bless all of you.
Well done. Thank you very much. That was excellently done. excellently done. When you come across somebody who knows his onions, it's always very easy to connect. He talked to us as a teacher. The experiential knowledge in particular actually touched me, giving some specific examples, illustrations, things that have happened. And I believe all of us were able to connect with those illustrations. And you are reflecting on your own mind. I wish I knew what you said today, way back in 2002. Perhaps I would have sued that hospital. And but luckily, the boy they wanted to kill is also now a lawyer today. Maybe tomorrow he will handle that himself. Distinguished ladies and gentlemen, we thank Professor Edozen most sincerely for this lecture. Thank you so much, sir. And we thank also Professor Asuzu for facilitating this. Now that we're in the spirit of appreciation, I want to call on the Chairman Local Organizing Committee to give the vote of thanks for this event so that we can bring the event to a close. Please, a round of applause for Professor Tesla.
Yeah, thank you so much. First and foremost, I have to appreciate the Almighty Allah that actually gave us this opportunity to hold this year as a third disciplinary discourse lecture of the postgraduate school. It was initially looking as if we couldn't do it, but thank God that we are here today and we've had this year's lecture. I want to appreciate the Dean Postgraduate School, Professor Azuzu, because 2 weeks ago, he came up with this idea. And I said I was wondering how it would be possible for us to do it within 2 weeks. And all he could say then was that, Teslim, you can do it. I said, okay, we'll try our best to see that we do it. And thank God we finally did it. And I also have to appreciate the chief executive of this institution, the Honorable Vice Chancellor. During our first meeting with him, when everybody was making different demands, I did not demand for any other thing apart from how we are going to hold this PG lecture as our first official outing. And there was a crossroad. We had the acting Vice Chancellor in the first week of planning. Then the second week of planning, the new VC came in, and we were wondering, how do we even do this? But that very day, the chief executive gave a verbal approval that all what we have demanded for this occasion to hold, that she has approved it. And he actually lived up to expectation. And when he got to a stage that she would not be around, she asked the Deputy Vice Chancellor Academics to stand in for her. And just yesterday, when I messaged the Deputy Vice Chancellor Academics, all she told me was that I will be there. And thank God that she's here. Thank you so much. I also have to thank, well, I don't have to thank the Dean PG School because he really taxed us. And the only thing I can just say is that we really appreciated the confidence he had in the planning committee that we can do it and we are able to deliver. I will have to thank my committee members, starting from Professor Onkiko, the Dean, Faculty of Sciences. She played an active role. And the current Vice Dean, who is unavoidably absent, is in Lagos to conduct external examination at the University of Lagos. I appreciate him too. And I also appreciate other members, Dr. Baba Yemi, for being part of the planning committee. The last but not the least is the secretary of the planning committee, Mrs. Fola Shadia Okweju. She was very wonderful throughout. And to other members of the management of this university, from the coordinator of the library to the assistant, to the acting registrar of the institution, and also the bursar. When I called the bursar this morning about this program. He told me that I won't be there. I said, why? He now gave the reason. I said, please don't come. I just asked him, okay, please, just don't bother to come. And I've also sent our apologies to the immediate past acting vice chancellor because we got very late to him. But he himself has actually he has made a lot of effort to see that we hold this event. And without all of you, the audience, we can't be here. I just have to appreciate all of you. Thank you so much. And we look forward to the 4th International Discourse Lecture of the PG School. Probably before this year runs out or early next week. And it will not be any other person apart from the Honorable Deputy Vice Chancellor of Academics, Professor Huuba, who will give the next one. Thank you so much, everybody, and have a nice day. Thank you.
Thank you very much, sir. For those who want to ask questions, it's an ongoing discussion. And luckily, we have Prof in our midst. Please feel free to interact with him. You can go to their faculty. You have a lot of things to learn. Distinguished ladies and gentlemen, we have come to the end of this discourse. And I want to appreciate you most sincerely for your cooperation. May I please crave our indulgence to stand once again as we finally draw the curtain on this event for this year with the UNIMED anthem. Thank you very much. We are going to have a group photograph inside because it is raining out there. It's drizzling, so and we don't want people to get wet.